Hey, it's me, Jen again, and today's interviewee has traveled the globe learning innovative surgical techniques for the thyroid, but now he's saving thyroids through RFA. We'll hear from Arizona surgeon Dr. Richard Harding after this. If you value this content, please subscribe to this channel because that really helps YouTube to put these videos in front of more people. And that helps more people be able to save their thyroid from surgery through radiofrequency ablation, a treatment that shrinks thyroid nodules directly and preserves the thyroid gland itself. Today, we're talking with Dr. Richard Harding of Phoenix, Arizona, a general surgeon with expertise in minimally invasive and endocrine surgeries. Dr. Harding has surgically removed many thyroids, but a desire to help preserve his patients' thyroids led him to RFA. Let's hear more from Dr. Harding about how this thyroid-sparing technology is drastically changing outcomes for his patients. I've heard that you are very well liked by some of our members of our Facebook group, and so it's really awesome to get to actually speak to you.
Yeah, thank you for having me.
We talked once before. You had learned about RFA for thyroid nodules around, I think, 2019, and had actually gone to Italy. Can you tell me that story again?
So there's actually a very, I would say, proactive and innovative endocrinologist here in Phoenix who was one of the pioneers of endocrine ultrasound and also fine needle aspiration, named Dr. Duick. And he was very much interested in radiofrequency ablation, but because of his own limitations, he was not able to actually progress it in his practice. But he did have an opportunity to go to Italy. When I was in Italy, his colleagues actually sought me out to express their salutations to Dr. Duick, and then the process invited me to come and learn more about radiofrequency ablation with them at their meetings. And this has been an interest of mine because it seems sometimes excessive to take thyroids out that have just benign nodules in it. And sometimes when you're actually doing the surgery, you feel almost kind of guilty to remove these nodules, knowing that there must be a better way to do it. And so I went to Italy and I took a class, and then I heard that there was another hands-on class in Rio de Janeiro, and that was pretty hard to pass that up. So I had a friendship with a physician in Rio de Janeiro, and I went down there where you got to do hands-on training, and that was fantastic. And then I started to prepare my patients for doing that, which meant, getting more biopsies and, basically stratifying them for those who are appropriate and not appropriate for the procedure. And then I started off in about February. I started late January, February. And so it took me several months to get started. And in the process, I got to go back, and they had an international meeting on thyroid nodule therapeutics, which was actually sponsored by one of the endocrinologists in Italy, and that was fantastic. It was a lot of fun.
I bet. You were in Italy, which is one of the three major places where RFA is kind of like a hot topic. It's like we've got Italy and we've got South Korea and we've got Brazil. So you got to go to 2 out of the 3.
And what's interesting is that you learn when you're there that this is being done everywhere except the United States. And the reason it is being done everywhere is it's actually being done by different specialties. It's actually being performed by interventional radiologists who specialize just in endocrinology, which is rare. We don't have those here. And so for a long while, they were trying to get the interventional radiologist to perform the procedure. And in the United States, they're already overworked. They don't really care. And they don't treat endocrine disease as opposed to the endocrinologists and the surgeons that treat it on a regular basis.
Yeah, my physician's actually an interventional radiologist, and he's not specialized in endocrine. So he can advise me on the procedure. He's very, very knowledgeable about the procedure. But if I have a question for him specific to thyroid or endocrine health, then that's something I have to go and seek out from, one of those specialties. So there's not very many interventional radiologists in the country that do this. Most of the time, endocrinologists and ENTs, a vast number of them are ENTs. And so It's interesting that this is a multidisciplinary procedure. In multiple areas of medicine, there's application for it. And you're a surgeon, correct?
Correct. I'm a general
So,
surgeon.
general surgeon. And you found that this was something you really felt was an invaluable tool to add to your toolkit.
Absolutely. So over the years, I do a lot of minimally invasive surgery. So I do robotic surgery. I do obviously laparoscopic surgery. And I was looking a way to incorporate this minimally invasive technique into my thyroid surgery. Since I did more thyroid surgery than everything else, it
Really?
seemed like it would make sense for me to do minimally invasive thyroid surgery. So I actually went to Thailand to learn endoscopic thyroid surgery. That was actually a couple years after learning robotic thyroid surgery. I started doing robotic surgery on the thyroid, and I just didn't like it at all. When Dr. Ankun Anawan presented his data to the American Association of Endocrine Surgery, it was really exciting. And so I had to corner him and ask him, how can I come out and learn this technique? And he says, just email me. And so I went out to Thailand, I learned that technique, and we did a lot for a while. And then this radiofrequency came up. This is much, much better. It's much faster for the patient. It's easier to perform. It takes a fraction of the time compared to surgery, do the procedure, and then there's essentially no recovery.
Right.
And so the patients are ready to go to work the next day.
Yeah, it's amazing. I am so thrilled with my experience personally. I've had 2 RFAs, and I would never have had my hair this short prior to that. I had a really big lump on this side of my neck, and I was kind of hiding behind longer hair for years. And I had my procedures and my neck shrank, and I felt better, which was the main thing. I felt so much better. But after some time passed, I was like, I could go shorter with my hair now because I don't have this cosmetic thing going on either. So it's been a huge blessing for me personally. And our Facebook group that we have for patients is up over 2,000. It's up to 2,200 people now.
Wow.
And
That's great.
so many positive stories about how this has been such an easy thing for them to go through, and that they're so thankful to be able to keep their thyroid intact and keep their function. So I'm so excited that you're offering this now.
The cosmetic benefit you see in a month. I mean, in a month, I've had patients with 54 centimeter thyroid nodules that shrink down to 24 centimeters in just the first 30 days, which is fantastic.
Wow.
And then usually in 3 months, you're looking at it and you're like, I don't even see it anymore. It's really remarkable. But the really neat group is the patients who are hyperthyroid and those who have cardiac palpitations from being borderline hyperthyroid, and they'll come back and say, my palpitations have gone away. I don't feel my heart beating anymore. Not to mention the thyroid's smaller, but they notice a big difference in how that's affecting their heart rate. And so that's really neat to see that.
We've got several members of our group who have experienced the changes from their hyperthyroid to being normal. Symptoms are disappearing. I have one friend in the group. She says, I used to snap at my husband and my kids, and now I just feel like a normal person, and it's such a blessing.
Well, hyperthyroidism kind of keeps them wide awake at night, interferes with their sleep.
Yeah.
And then if their heart is beating irregularly, then they're also quite nervous because of that.
Yeah.
And so
absolutely.
The combination of the two really creates problems for them.
I'm sure.
They can tell the difference almost immediately.
Wow, that's amazing. I know that the substernal goiter is quite an intense surgery, is it not, to remove a goiter that's down below the collarbone?
Well, I do a lot. So for me, not so much, but for many people, they're uncomfortable doing surgery down below the breastbone. But yes, it's a bigger operation. It's a lot more technically demanding.
Have you had patients who have had a substernal goiter that have been treated with RFA and had been able to avoid having that kind of a surgery?
I have not yet. And so one of the thoughts in regards to these patients is that you can treat them sequentially, and you can shrink the upper part of the thyroid. And then as the upper part of the thyroid shrinks, it'll pull the substernal part up out of the chest, and then you can treat the lower part on a second treatment. But I have not yet had those patients. I've had patients who've asked me to treat them, but because of other reasons, they were not candidates for that initial treatment.
Okay, I see that.
And that's very important because a lot of patients come looking for radiofrequency ablation, and they have other issues which make them not a candidate at all.
Right.
And after you point those out, or you do the biopsies and that sort of thing, and you you demonstrate to them why they're not a candidate, they're very accepting of it. But I mean, obviously they're disappointed.
Patients who at least know for a fact that they've sought this out and been told, okay, you're not a candidate, they at least can sleep at night knowing, well, I did all my homework and I know for a fact that this wasn't the right course of action for me personally. But I only ask you about the substernal goiter because that was actually my personal situation. It wasn't tremendously low behind the collarbone, but it was a portion of it was behind my collarbone. And so I had about 80% of mine treated. Mine was kind of an L shape is what my doctor described it as. It was very long. And then at the point of my collarbone, it was kind of the long portion of the bottom part. And so he treated 80%. And then 9 months later, the rest of it had moved up. And he treated that part.
Exactly. And in fact, the doctor in Brazil which is Dr. Leo Rangel. He actually did a live simultask procedure when he was trying to do that, and it was really challenging for him. It was it was certainly a difficult case. It's hard to see the thyroid underneath the collarbone and very deep. The really deep ones, you have to be able to see the tip of your probe, and it really becomes challenging to see that. And so you push the limits of safety of the procedure when you're doing that on really, really big ones.
He treated all of the upper part, and then everything he could not see behind my collarbone, we just waited till that second one. So are you offering any kind of training, or are you having doctors come and observe you and offering this procedure now?
So I've had the local doctors here in Phoenix come and watch, and I have my colleagues on the East Coast that have asked to come and watch, and it's just a matter of coordination. Usually if you're going to do that, you want to have at least 2 cases to make it worthwhile to come. And right now, the number of patients coming in is usually 1 or 2 a month right now. And so it hasn't really worked out that we can get a long lineup of cases, but it would be fantastic to get that lineup and then just do a bunch for a training. But I've had several come over just to demonstrate, to them how it works and how the patients tolerate it quite well, and it's been a good thing. So I train residents on a regular basis, and they're certainly enjoying it.
Oh, that's cool. So you're getting student doctors in there learning how to do this before they even actually are practicing.
So they are not going to be doing this in practice. So really, when you're looking at the doctors who are going to be doing this in practice, it really needs to be doctors who've really mastered the ultrasound guidance and the techniques using 2 hands and usually getting your stereotaxis all together where you can really see the needle going into the thyroid and can control it, and then understand what you're looking at before you even do the procedure. And a lot of people don't have that skill set where they really understand what the thyroid is supposed to look like when it's a benign nodule, and then what the thyroid is supposed to look like when it's a cancer, and then the in-between nodules. And you really need to have an understanding of what is an acceptable nodule, which is benign. And the other group are patients who've got Hashimoto's thyroiditis, and they really have irregular looking nodules. And in fact, they don't even have nodules. The Hashimoto's thyroiditis affects the whole gland. And so they get what's called pseudonodularity. And they'll come in reports of a really big nodule. When you look at the images, you really understand that these are just kind of like looking at animals in the clouds where the radiologist or the tech is envisioning areas of nodularity, and they're trying to demonstrate a border around it. But when you really look at it, the whole gland is involved. And those patients would basically have to have the entire gland ablated to get rid of the abnormality, which is not a good idea.
We did have one person mention that she had Hashimoto's and her lab work dropped her down into the hypothyroid area, but she was saying that her physician expected that her thyroid was going to pick back up after the fact, but that it was unusual and that they had not encountered that with any of their cases up to this point. It's interesting that you mentioned that the thyroid gland in Hashimoto's would have that different appearance. I'm assuming since you've done a lot of thyroid surgeries, you've probably seen a lot of these thyroid glands up close and personal, and they look very different from a healthy thyroid gland.
Yes, they're very fleshy, and they have a lot of external nodularity to them, and they tend to be very vascular as well.
Really?
And the tissue is quite hard. And so my concern in treating those patients, because a lot of patients, they don't care. They just don't want surgery. They would prefer to just undergo ablation and have their thyroid nodules shrunken. But this is a different pathology altogether. The gland is very hard, and it would take a lot of energy just to kill it. And then because it's so hard, to be uncertain how it would behave after you kill the internal part of it. In other words, I just don't think that the patients would be happy with the results that they would get.
So in your particular practice, you would probably advise against RFA for Hashimoto's patient?
Correct.
Well, and that makes really a lot of sense the way you explained it. I had not heard that before.
In general, we don't recommend it in patients who are hypothyroid. And I don't think it's going to make people's antibody levels go up necessarily, but I don't think there's enough studies out there looking at patients who've got anti-TPO antibodies before and after their radiofrequency ablation to see if it goes up. So I think that would be an area that's worth looking into. The gland is very hard. Even if you treated the middle of it, you're still going to have a hardened, enlarged gland after the procedure. And I just don't see it shrinking the way you really want to see a normal gland shrink.
And if the autoimmune attack is still continuing on, you may continue to develop those abnormalities as time goes on anyway. So let's talk about what you're seeing in your patients that you're performing this procedure on. What kind of data are you seeing?
So we follow them at 1 month, 3 months, and 6 months after the surgery, and then in 1 year as well. At 1 month, I'm seeing in general about 40% drop in size of the nodule, but I have many that come back with 50% drop in the first month. And then I have many at 3 months that have already dropped down below 75% drop. And that's just in 3 months. And so we hope that patients will have an 80%. I mean, I'm aiming for 80 at a year, but I'm seeing that at not quite at 3, but at 6 months, I'm certainly seeing that. Now their nodules change significantly and they look a lot different because they're no longer viable. But the patients, the whole thyroid shrinks. And it's dramatic, what we're seeing. So that's very exciting to see, because we tried to match the world literature, the world experience, for instance, in Korea. After going to that second endocrine meeting and hearing about how many cases had to be done again, and then the panels in Korea and in Italy were saying, well, the reason the patient needed a second treatment is because it was inadequately treated the first time. And so because of that, I took the message that I really just need to do a complete job as possible. And as a result, we're getting fantastic results. Yeah. That's
fantastic. So, yeah, I have a lot of patients ask me, is there a risk of the nodule growing back? And the data that I have read overwhelmingly says that the risk of it is very, very low when it's treated adequately at the first treatment. Does that agree with what you're seeing?
Yes, because if you don't get the margins of the tumor, that margin will still get its blood supply from the periphery. So you really need to get all the way to the margin to get that marginal blood vessels. And because those are the areas that you still see that are viable afterwards. And really huge nodules, when they shrink 80%, it's hard to imagine that nodule would ever grow back. But I've had patients who were treated elsewhere who have been treated by me for a second treatment, and you really need to apply enough energy to prevent it from coming back. So we're keeping track not only of the size of the nodules, but also how much energy that we give to the patient per milliliter of tissue. That's going to be very important in the future.
So it's not just where you treat, but how intensely you treat.
Correct. The amount of joules per centimeter squared.
So the more intensity, the more effectiveness?
Right, but also the more potential for injury. So as long as your probe's in the middle of the thyroid nodule, you should be okay. The potential is that if you are not exactly where you want to be, you could have an untoward problem.
Gotcha.
And so that's why your expertise has got to be there in terms of knowing where everything is all the time.
When people have nodules that are highly vascular, is there more of a slow reduction in size due to that vascularity continuing to feed the nodule?
Well, I mean, when you're doing the procedure, the nodules don't heat up as much. And so you'll see the resistance. There's actually a resistance indicator on our machine. And when they have a lot of vascularity, the resistance doesn't go up as fast. And so you just have to keep applying the heat. If you have a perforator on the edge of it, that perforator could keep that tissue, and it's not like it's insulated, it just doesn't heat up as much. So the likelihood of having viable tissue remain there is a lot higher.
Okay.
And so some experts will tell you to go and get those perforators first, going around and get the perforators and then come back and do the rest of the thyroid. And that's truly an advanced skill,
Mm-hmm.
because once you get those perforators, your whole nodule changes in its appearance, and it becomes a lot more technically demanding to treat it because it all looks so much different.
Okay. Okay.
Yeah.
So what you're seeing on ultrasound changes like in real time.
Very, very much so. Yeah.
Okay.
And right. I mean, it's really astonishing how much it changes after you turn that machine on.
Wow.
And then it'll change back, but it takes a while for it to change back.
So when those nodules are treated, do they reduce as much as the non-vascular nodules do, or is the rate of success just as high?
Yes, but you could get the peripheral growth back, and just time will tell how fast they'll grow back.
Are you mostly treating patients just once, since you were mentioning how, you try to do an extremely thorough job on that first treatment? Are you having to see any patients more than once?
Well, I had one patient I treated more than once. She had 5 nodules, and we were able to treat 4 of them, and then she started having side effects from the anesthesia. So we had to stop before the 5th nodule was treated. Okay. So we brought her back and we treated the 5th one later, and that worked really well. But that we gave it a whole year before we needed to do that. And in that year, that nodule got bigger, which was interesting to see. Yeah. So her nodules on one side shrank by 80%, but that one nodule almost doubled in size within the year that we were watching it, which is sometimes happens with 9 thyroid nodules.
Yeah, it's interesting you said that. So the nodule that I had treated was on my right side, and it was very large. It was around 65 to 75 milliliters in volume. Then I have another very small one on the left side that is around 1 centimeter in size, and I'm curious to see if it's going to get big enough that I have to have it treated, or if it'll just stay stable, because so far it has remained stable, but only time will tell. So
right. And so these discussions we have with patients all the time is just the natural history of thyroid nodules. 65 to 70% will not change in size at all over time. So if patients are having symptoms, well, that you can tell you, well, you have symptoms, and 70% of the time it isn't going to change. So that means that 70% of the time your symptoms are going to remain the same. They're not going to get better with nothing. And then you have about 15% that are going to get bigger. And if you have a patient who's already demonstrating that the nodules are getting bigger, then you know for certainty that it's going to continue to enlarge because they've already declared themselves which type of nodule that they have. Those patients are basically easy to categorize in terms of needing treatment. But the nodule has to be over 2 centimeters in size before you even bother treating it. That's important distinction to make, because a lot of people will come in with small nodules. They'll declare themselves symptomatic, but I have to basically let them know that I don't believe that their nodules are big enough to cause those symptoms.
And is it normally just the size, or does the location play a role?
Oh, very much so. Location is very important. So, for instance, some patients have a large thyroid nodule that you can see, and everybody can see. You're convinced that they're going to have symptoms from it, and they'll say, no, it doesn't bother me at all. And then you'll have patients who have a deep nodule next to the esophagus and underneath the collarbone, and theirs isn't very big at all, but yet it's quite symptomatic because it pushes on the esophagus. The location is very important. And those are actually harder to treat. The big ones that you can see are easy to treat. The ones that are deep and underneath there, those are the ones that are harder to get to because of the angles involved.
Yep, that was me. That was me. My trachea and esophagus were deviated to the left, and my airway was compressed by about half. So I was highly symptomatic, and it all happened. It came on severely, very rapidly after I had an allergic reaction to an antibiotic. I was symptomatic only in the very slightest amount. And then once I had this allergic reaction, I instantly became highly symptomatic. Everything enlarged. My thyroid swelled, but also the nodule doubled in size, and everything just got totally worse overnight, which is not something that I've heard any other patient in the group
I've not
describe.
heard that.
It's a very weird thing.
I'm glad we don't see that, because that becomes a real problem.
Yeah, it was a tremendous problem for me, because I was being recommended surgery because it was so terrible. I was very concerned about having surgery, given that I actually had 2 knee surgeries when I was 18 years old that resulted in me having a systemic case of staph infection that I almost died from. and it was horrible. The antibiotic that I actually had this allergic reaction to was what I was given for that staph infection when I was 18. So, I asked my local physician that was offering to do the surgery for me, well, what would you do if I had this same situation again? Because I'm allergic to so many of the antibiotics.
Right. That's a big problem.
So what are you going to do if I end up in this situation again? And he's like, well, we'll just let the infectious disease department handle it, which I was not satisfied.
That's not too terribly reassuring.
No, not at all. I was like, this is not a very proactive way to handle the situation. So that's why I sought out RFA, because I just felt like I didn't want to get myself into that situation of needing to deal with an infection. That's why I was so thankful to be able to have RFA. And I'm so thankful now that we have more physicians offering it. Yourself and so many others are deciding to bring this on in spite of the fact that your colleagues are, not interested yet. They're, I don't know. Did you have colleagues that were like, are you crazy? Why would you do this?
Well, a lot of it has to do with how well you think the patients are going to tolerate it. And so a lot of the patients are like, you're really doing that in your office? You got to be kidding me. And so when I'm doing it in my office, my patients are saying, this is even better than going to the dentist. This isn't bad at all. I had one patient, she actually slept through the entire procedure, and I had to keep waking her up just so I could hear that she was breathing during the procedure because she was so soundly asleep. I mean, we were laughing because we couldn't believe how well it was being tolerated. And so I think over time we get better at it, which is great. And but the patients seem to tolerate quite well. Some will have a reaction to the local anesthetic though, and it takes them a while to get over it. So, but we've been able to work through it. Yeah.
So you use local lidocaine and conscious sedation?
I don't use any conscious sedation. I just use lidocaine.
Okay.
Some people will offer Ativan or Xanax, and most patients don't want it. Most patients just say, I'm going to be fine. And then, but of course, some of those patients you wish you gave it to, but at the same time, they do fine. After the first couple of minutes, they realize what's happening and they're quite comfortable.
One of the most common things I've seen in our group, patients are very nervous going into the procedure because it's not like anything they've ever had done before. The fact that you're going to be awake, and they're nervous about the unknowns, which is a big part of why we try to promote education about this so much, is just to take away those nerves. But there's still some anxiety there. And then so many of them afterwards will say, I can't believe I was nervous about this. It was so easy. It was no big deal at all. And especially, having a doctor who can reassure them about what's happening and explain the process to them, that makes a world of a difference too. I think in the last 2 years that we've had the group, I've only heard one person say, this was horrible and I don't ever want to have it done again.
And it's also very helpful to do your own biopsies because you can kind of just figure out what patients are going to be okay just by how they handle the biopsy. Because if they can if they're very comfortable for the biopsy, then they should be quite comfortable for the procedure. And there's a lot of patients that have had a bad experience with the biopsy, and it may be that the person who did the biopsy didn't have a whole heck of a lot of experience, and therefore gave them a bad experience or painful and that sort of thing. And so so that's why I like to be the one doing the biopsy, because I can kind of watch them and see how they respond, and then at least assure them that it's not going to be miserable. And so they'll feel it. They feel stuff, but it's not pain. Most people say, I'm not experiencing any pain. I can just feel what you're doing. And that's how they describe it to us.
It's kind of like a weird pressure, and then you can feel the popping when that starts, but it's not painful. It's just kind of weird. It's like, what was that? What am I popping from the inside out?
We making the popping into more like a celebration, like woohoo.
Yeah.
We're hearing popping because that means it's working,
It's fireworks.
So, yeah, exactly. So we kind of turn that into fun.
There's been a few patients more recently, and they're not from the same doctor. They're all from various different doctors. And it's not been a tremendous number of patients. I would say a handful who've commented that they've had more pain in having these procedures done. I'm not sure if they have a lower pain tolerance, or if maybe they needed more lidocaine, or if they had, as you said, a negative reaction to the anesthesia. What are some reasons that you would think a patient might experience pain considering that most patients don't experience any pain with this procedure at all?
So I would say that when I started the procedure, I was using somewhere between 30 to 40 cc's of lidocaine. And as I'm doing more, I'm using closer to 20 now. So much less. In certain patients, you need, if it's really close to the trachea, sometimes you need to put a little local anesthesia between the thyroid and the trachea. And patients don't like that at all because the trachea is very sensitive. So when you're actually administering that lidocaine between the thyroid and the trachea, that actually hurts. It works, but it's not comfortable. And so that may be why. It just, you know, if the lesion's really close to the windpipe, they can have pain. Or if the doctor used less anesthetic because patients seem to tolerate it without as much. Because you can have side effects from too much anesthesia.
Right. So
if they can do great with less, then that's fine. And so just as long as we offer more anesthesia if they don't tolerate it, that's what I tell patients. If you're having pain, let me know so we can give you more. And they have to let it work. So one of the tricks that I've learned is before I open up the probe, I'll do the block first and then let the block work. And then while the block is working, then I'll set up the equipment for the procedure. And then that gives a couple minutes time for that lidocaine to work.
It takes it a little while for it to kick in and give the full effect.
And you learn that as a surgery resident, because when we were a surgery resident, we used to close scalp lacerations. And if you just start numbing it up and start closing it, the patients had a lot of pain. So you learn to basically give the local anesthesia, walk away for a while, and then come back and do the procedure, and they tolerate it much better. So that's just the nature of experience with local anesthetics.
Yeah, I wish we had a way of tracking the data of, you know, what these patients' different situations were, because, you know, I don't know that they all had the same factors at play causing them to have more pain. I just know that there's been a small number of them lately, which of course, unfortunately, causes a lot of the patients who've not had this yet to be concerned that it's going to hurt, which is, you know, I'm always trying to reassure patients this is not a terrible procedure at all. It's much less painful to have than, well, I mean, like you mentioned, that patients feel like it's not even as bad as going to the dentist. And I can tell you, I love my dentist and he's great, but the last time I had a filling, it was not pleasant. And it was not even a major filling. It was very small. Tracking this data will be something, I'm hoping that at some point down the road, we'll have a way to maybe take advantage of the fact that we have this body of patients now providing us with data where we can say, you know, so many percentage of patients experience XYZ, so that we can use that information to help make this procedure better.
And Korea has already done that in their literature, where they look at subtypes of nodules and the locations of nodules, and what is the best way to use what they describe tumescent anesthesia, where you're injecting saline and with a little dextrose in it between the thyroid and the muscle, between the thyroid and the trachea, between the thyroid and the carotid artery. And they have all sorts of outlines that we can use to optimize our anesthetic administration. Maybe, you know, they could have been given a lot more fluid and they would have been tolerated better. Once the insurance companies kick in a little bit better than they are, I think that'll change the whole profile completely.
Absolutely.
In terms of how many we're going to do, because I've seen handfuls of patients who would benefit tremendously, and they're just going to wait. Since it's benign, it's reasonable to wait for them. They have symptoms, but it's not too bad. But other patients' thought is, I guess, from the insurance companies, is that if you're that bad, just have surgery. And right now, that's what we're doing. So we're looking forward to the time where we can just say, look, this is better, get this done.
It's such a shame, you know, because the cost of surgery is so high when you compare it to the cost of this procedure. It's just that it's covered by insurance. So
that'll change, but it's going to take a bunch of people and a lot of data. My data is overwhelmingly positive, so it's been fantastic to see.
Is there anything from any interesting experiences or just words of wisdom to either physicians or to patients from that year and a half of experience that you would just like to put out into the world?
Well, I think, from a physician standpoint, a lot of doctors think that because they're surgeons, they can do anything, and then they should be able to do it because if they're taking out thyroids, they can do this. And I would point out to them that it's a lot harder than it looks. But fortunately, and it's not necessarily limited to surgeons. Obviously, there's endocrinologists. It's just a matter of getting the hand skills, the ultrasound skills together in practice. And they can do it in practice and get that. But they should start now if they think they're going to offer it in the future, and just start doing your own ultrasound guided biopsies and that sort of thing. From a patient standpoint, my patients have been absolutely delighted they've chosen this route. The ones that are in town, they come back and we examine them and we look at their thyroid, and they're just absolutely thrilled to see how much it's gone down in size, and their symptoms by 3 months are basically gone, which is really terrific to see. At 1 month, they still notice it, but at 3 months, they're definitely gone. And then by 6 months and stuff, they've sort of forgotten all about it. So that's a great, to me, that's a great outcome. It's hard not to encourage patients to go that route, in other words, when you see how well they do.
My hope is that as this becomes more known, that this will become the way that this will be the standard, that thyroid nodules are treated this way the majority of the time.
And so it's interesting because when we go to European meetings and just, or even zoom in on European meetings, it's very commonplace right now. It's so commonplace that it's just automatic for these doctors to say, okay, 75-year-old guy, benign nodule, we're not even going to offer surgery. We're just going to ablate it. But yet in the United States, we're just behind. And I think it's just a matter of us catching up, and hopefully that'll be soon. But thank you for your efforts in making this more of a public issue, because it really is a huge benefit for patients. And they look at your site as something that they can trust and believe in. So that's a good thing.
I don't take that for granted, Dr. Harding, one bit. I am very aware that as a resource that people trust, I want people to know that this is important to me. This is personal for me because I've gone through it myself. So, but thank you for saying that. I appreciate that. It's so nice to hear a physician remark like that to me. It means a lot.
Thank you so much for watching. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next interview right here.